Hello and welcome to a special interview for The Wire supported by Glenlivet Books. Has the Omicron wave peaked and is it now subsiding and retreating? And what do we make of the fact that in percentage terms, the number of cases and deaths in Maharashtra and Kerala are greater than those in UP and Bihar, even though UP and Bihar have a far bigger population? Those are two of the issues I shall raise today with Professor of Virology at the Christian Medical College in Vellore, Gagandeep Kang, and Professor of Physics and Biology at Ashoka University in Sonipat, Gautam Menon. Professor Menon, let me start with you. After touching nearly 350,000 daily cases on the 20th of January, now the daily case tally is around 215,000. Over the same period of time, the positivity rate has fallen from 21% to around 15%. Does this suggest that the Omicron wave has peaked and is now steadily subsiding and retreating?
I think it does suggest that. And if you look at what models had predicted, they suggested that you would see a peak somewhere between the 20th of January and the 10th of February, with the big cities in India, bigger states, peaking a little earlier, probably closer to the 20th, and the rest of India following roughly in the period between the 20th of January and the 10th of February. And that's what we're seeing is pretty much consistent with that. And I think that's a positive because many models really were saying the same thing. So we do seem to be on the downswing of the slope, and I think that's a positive.
Do we have a clear idea, Professor Menon, of what the R number is? A couple of days ago, Sita Sinha was quoted in the papers saying it had fallen below 1. Do you believe that to be the case?
Well, active cases are actually decreasing on a day-to-day basis. So that's certainly an indication that you have come to a situation where you're not generating more cases than would be expected. The R is essentially an indication of how many cases are generated by someone who's infected. Once it drops below 1, then that means that the epidemic is on its way down. And that certainly is the case. It's consistent with everything that we know at the moment.
So you do believe it is below 1 at the moment?
I do believe it's below 1 at the moment, yes.
Professor Kang, if the wave has peaked and is steadily receding, doesn't it mean that Omicron has behaved very similarly in India compared to the way it behaved in South Africa, where it rose dramatically, peaked, and then fell equally rapidly?
Absolutely, it does. So I think we've been fortunate in having an age structure of the population that is very similar to what is seen in South Africa, and two, having high levels of prior exposure and reasonable levels of vaccination, which have meant that even though this is a virus that has a lot of immune escape, it was able to transmit very rapidly, but ran out of people to put in hospital pretty quickly.
And is this also the similarity with South Africa reflected when we look at the severity of the disease in India? The Hindustan Times runs a tracker of hospital beds in 13 critical regions and states, and that shows that 86% of hospital beds are empty.
So this is actually something that a lot of people are referring to, decoupling of cases from hospitalizations. And it was first seen with the Delta wave in the UK, where when they vaccinated a lot of individuals, the bulk of their population that was at high risk, they saw a decrease in their hospitalization rates. It's become even clearer with Omicron, and there are data from multiple parts of the world that are showing that if you have an infected and a vaccinated population, then case numbers may rise, but hospitalizations will not.
Let me turn to something else. Professor Menon, how do you judge and assess the fact that in percentage terms of population, the number of cases in Maharashtra and Kerala, both cases and deaths, seem to be greater than UP and Bihar, although UP and Bihar have a considerably bigger population? Is this an indication of some measure of laxity, or is it the opposite? Does it suggest good detection in Kerala and Maharashtra and a more effective healthcare system? Which of the two?
So let's look at that question again and ask, what are the parameters by which you decide whether a state does well or doesn't? And one way to do that would be to compare the number of infections in the population in that state, obtained by a serological study, which really looks at the antibodies that are there and that have been generated either from a vaccination or from a prior infection, and compare that to a record of an official record of how many cases the state had. And that's where the gap becomes very, very apparent. For in Kerala, in the previous wave, in the Delta wave, the factor was about 6 or 7. For UP, the factor was about 100. So for every 1 detected case, there were 100 undetected cases. In Kerala, for every 6 undetected cases, there was 1 detected case. So that suggests, so that gap is really an indicator of how well the public health system picks up new cases. That would be the real index. And the same is true for Maharashtra. So these states had low seropositivity compared to the average across the rest of India. So they were doing a better job of controlling the infection compared to the rest of India. By exactly that same analysis, other states in India were not doing as good a job. They were not picking up cases. That gap was considerably larger. And that, I think, is the real way to think about it. What exactly is the discrepancy between the official numbers and the actual numbers as inferred through some sort of measure that is objective, such as a serological study?
So in layman's language, what you're saying, and correct me if I'm wrong, Professor Menon, is that when people look at statistics broadly presented without context in a newspaper and say, oh, you got that many more cases in Kerala and Maharashtra and so much fewer in UP and Bihar, and therefore come to the conclusion that UP and Bihar are doing better, actually, they've come to the wrong conclusion. The reason why Kerala has more cases or Maharashtra does is because A, they did a very good job at protecting people and therefore the seropositivity level was low. And now they're doing an even better job at treating them when they do fall in. That's not the case in UP, where for every single detected case, 100 are missed.
So that's broadly true. When you look at numbers, you have to understand the context of those numbers and the way they present it and what they mean. So that's certainly something to worry about. Overall, now we believe that Omicron is a milder than the earlier Delta variant. That certainly seems to be true, as Professor Kang spoke about the decoupling between the cases and, for example, hospitalizations. The fact that these populations, the Kerala population, the UP population, just to take these 2 examples, are very different in the way they're structured in age. Kerala is one of the oldest states in the country. UP is among the youngest. All of this factors in. If you have a population that is young, will barely notice the disease when it strikes it, that certainly impacts that population differently from a population that is older on average, has many pre-existing conditions that predispose you to worse outcomes, is well connected internationally, is much more urbanized. Many of these details enter. So it's a little hard to compare different states on very simple metrics. We should be aware of all of this when we think of the numbers.
Would you agree with that basic point, Professor Kang, that without the context and the background, when you look at the bold statistics presented either on television or in newspapers, people tend to come to the wrong conclusion about Kerala and Maharashtra and believe that, in fact, it's doing a lot worse, whereas the truth is they've done probably better than most other states.
Oh, absolutely. I think the most objective data we have, the most balanced across the country, really has been the sero surveys. And those sero surveys have told us about the levels of infection in different parts of the country and have clearly demonstrated that we acquired high levels of infections in adults and children across the country. And for both children and adults, the lowest levels of seropositivity were in Kerala. And as Gautam pointed out, that is the state that is the oldest, therefore should have the highest risk factors. A lot has been made out in the media currently about the deaths in Kerala that are currently being reconciled and the high numbers that are being reported now. I would argue, as others have done, that this leads to a sort of changing of the metrics and an inability to use them appropriately when the deaths are reported long after they have occurred. It would make much more sense to revise the older figures to show the deaths when they actually happen. But even with these high numbers being reported now from Kerala, we have to look at the fact that the mortality rate is still lower than the rest of the country, which means that while we might want an improvement in healthcare systems across the country, in Kerala, they are doing a good job of keeping mortality rates low.
Let me ask you a follow-up question, Professor Kang. In July, when I interviewed you, just after the second wave had receded, you said that in terms of its testing, its strike rate, its vaccination rate, and its mortality rate, Kerala had done a superb job controlling the spread of the virus and was a role model for other states. Now, as you are in the third wave, would you have the same opinion of Kerala?
I think after the last elections, from what I've heard on the ground, Kerala let a few things slip, but by and large, Kerala should be comparing itself to other countries in the world, not necessarily to other states in India, because it has a reporting system, a healthcare infrastructure that is more like many middle income countries rather than many of the states in the country that are like low income countries around the world. So has Kerala done a good job? Absolutely. Has it done the best it could? I'm sure there's always room for improvement.
Professor Menon, given that Omicron has become by far the dominant variant in India, and given that it's far more infectious than earlier variants, but the disease that it causes is considerably milder, do we need to shift the focus of our public health strategy for tackling coronavirus? Should now, thereafter, should there be less emphasis on testing, tracking, and tracing, and perhaps more focus on hospitalization and, in particular, ICU beds, the need for oxygen and ventilation?
For Omicron, probably yes, given what we know. But that's not a strategy for the future. I mean, we are not sure what new variant might come along. So we must make sure that we have all of these elements in place to track, trace, and isolate. This is a sort of larger question of what might be the trajectory of Omicron, of COVID-19 over the longer term. And the answer is that we don't know, but we have to be prepared. We are currently dealing with Omicron, which luckily seems to be milder, but we cannot base a future strategy just on that. We have to be prepared for what will come, and testing, tracing, and isolation is an invaluable and important component of that.
So what you're saying is we need to keep our capacity to test, trace, and isolate ready and intact. But at the moment, whilst Omicron is dominant, it doesn't have to have the emphasis it did when Delta was the dominant strain.
I would say roughly that. I mean, even though it sort of pains me a little bit to say that, because in general, this is how we control the spread of infectious diseases. But given the constraints that we have right now, given the fact that Omicron has pretty much spread across the country, and it's a fait accompli at this stage, I think this would be, at this point, a reasonable way to proceed.
To what extent do you agree with that, and to what extent do you disagree, Professor Kang? Because I noticed that you were smiling right through Professor Menon's answer.
Well, I think test, track, and isolate makes sense in the early stages of a new variant. After that, in the situation that we are in today, you probably need some level of sentinel surveillance, but you don't need the kind of effort that we are investing. Given the history of infection, given the vaccination rates, I think a sensible strategy to pursue for testing is to make sure that people who have symptoms, SARI surveillance, severe acute respiratory illness surveillance, should be implemented countrywide. I also think that we need some sentinel cohorts where we can study what is happening in the community. You can have some high-risk cohorts like healthcare workers or the immunocompromised. That is from a research perspective to inform what is happening in the country and to serve as early warning signals. We should be looking at what's happening around the world in terms of the emergence of new variants and be ready to implement surveillance specifically for those as and when they become available. And the one thing that we are not doing well that I think we should be doing is much, much more environmental surveillance. If you want a reflection of what's happening in the community, there is a tool available to us, sewage sampling, essentially, that we are not using.
Absolutely. Let me ask you two quick follow-up questions. Professor Kang, to begin with, Given what you've said, do you think the daily focus of television channels and newspapers on the number of cases recorded the day before or on the positivity rate is both unnecessary and could be misleading?
Absolutely. I mean, I would love to see if we really were tracking daily numbers for one infectious disease, why can't we do it for 5? Can we do tuberculosis? I'd love to see numbers for tuberculosis, for HIV, for outbreaks, typhoid. If we can do it for one, we should do it for all. The time for doing this kind of surveillance for SARS-CoV-2, I think, is coming to a close. Weekly, maybe, monthly, probably.
One more follow-up question. In this context, how worried are you by BA2, which is one of the lineages of Omicron? I noticed that the United Kingdom's Health Security Agency said yesterday, or maybe it was Saturday, that it has a substantial growth advantage over BA1, though so far there's no reason to believe the disease is more severe. So how concerned are you by BA2?
So at the moment, I think it's something that needs to be tracked, but there are no signals that indicate that we need to do anything more about it other than continuing to watch it. The UK Health Security Agency has been absolutely phenomenal in linking together information on genomic surveillance, on vaccination, and on clinical status of patients that are infected with particular variants. And so far, what that is telling us is that while BA2 seems to be growing faster than BA1 did, the vaccines are still working.
Professor Menon, do we have a reasonably good idea of how far BA2 has spread in India? I'll ask this question because we've just recently read in the papers that INSACOG has reduced the amount of genome sequencing it's doing because apparently there is a shortage of reagents in the country. We need to import them and we're having problems importing them. So are we doing enough BA2 tracking?
The data that I have seen from one particular Indian city suggests that BA2 has pretty much taken over. In a sense, that's good because we don't have to wait for something that will happen in the future that is more transmissible. BA2 does seem to be an essential part of the landscape, the current landscape, at least reasoning from that city in the limited amount of data that we have. And as Professor Kang said, there doesn't seem to be any serious reason to worry. It's just a new variant that spreads a little bit faster than the older variant, the older subvariant, technically.
Are you worried by this shortage of reagents so that the level of genome sequencing has reduced? Is that worrying?
That is worrying, because if something new is happening, you want to know what's happening and where it's happening. If you suddenly see a rise in cases, many more infections, much more household transmission, you want to be able to tell where that's coming from. Just remember that this was a signal of Delta in parts of Maharashtra in early February, early to mid-February. And had you caught it then, you might have taken it a little more seriously at that point. So we have to do this. I mean, this is.
So we're running short of reagents and reducing sequencing just when we need to be keeping it up or increasing it. Isn't that what you're saying also?
At least keep it at current levels, which are not very high at the moment. But you do need this in the future. You need to be able to do this in the future precisely to catch strange changes, strange anomalies that you see in cases and sudden increases and to attribute a cause to that.
We're coming to the end of this interview. Professor Kang, we are in circumstances where there's not much we can do to control the spread of infection, which is why this daily monitoring of cases may not be as relevant as it used to be. But we still can do an awful lot to protect against serious illness and hospitalization. And in those circumstances, how important are boosters? In Europe and America, they are now being given to every adult. But according to the Times of India 4 days ago on the 27th, on their very front page, the paper said, the government is considering not giving boosters to people beyond those sections of the population who are presently entitled to receive it. Would this decision not to expand to other sections of the population be wise and sensible, or would it be a serious mistake?
At the moment, given the lack of widespread effectiveness data on 2 doses in the country, I don't know what we would base a decision on 3 doses on. We've just started our 3rd booster dose in the vulnerable population. And we need to understand whether in the rest of the population, protection from 2 doses has waned or not. Since we haven't had effectiveness data in the past, it's very hard to tell whether effectiveness of vaccine has waned over time or with Omicron. So I think given we are essentially going to have to base our decisions on what we are seeing in terms of cases and numbers. And given the high rates of infection in the country, the low levels of hospitalization that we are seeing at the moment, I'm not sure that boosters for the rest of the population are needed for dealing with Omicron. Will this be required in the future for another variant is a different question.
Can I put it like this? There's no doubt that we don't have data that tracks the efficacy of vaccines in India, or if that data exists, the government has kept it to itself and it hasn't been made public. But either way, you and I don't have that data, so we don't have the data on the basis of which to argue there's a good case for giving boosters. But the rest of the world has that data pertaining to their independent countries. UK has it, Europe has it, Israel has it, America has it. Surely that data should apply to us. We're not unique, are we? Why would we be any different?
Yes, we are.
We are? In what sense?
Age distribution is different, and that is a significant difference from the countries that have a lot of data on vaccine effectiveness. Our exposure to Delta was different from the rest of the world. The vaccines that we are using are different. And I don't think we are in a situation where we can just take data from the rest of the world and apply it to ourselves.
Can I put this to you? No doubt in terms of the age distribution, we're different, and no doubt in terms of exposure to Delta, we're different, but the vaccines are the same. 90% of ours are Covishield, and that's AstraZeneca, and AstraZeneca was extensively given in Britain.
So I will point out to you that the distribution of the use of the AstraZeneca vaccine in other parts of the world is not the same as in India. In India, it was given to everybody 18 and up, whereas other countries have used largely mRNA vaccines. After the initial use of AstraZeneca, it was limited to older individuals. So we cannot directly compare the rest of the world's data to what's happening in India.
So just so that there's clarity for the audience, what you're saying is that we cannot give boosters to those sections of the population that haven't got it as yet, which, by the way, I suspect is the majority of the country, on the basis of data got from abroad. For the reasons you've mentioned, that data doesn't apply to us. The age distribution is different, the exposure to Delta is different, and even the age distribution of those who got Covishield or AstraZeneca is different to our country. Therefore, until we have our own data, you believe you're not sure boosters are needed for dealing with Omicron.
Absolutely correct.
Professor Menon, is it therefore time to open schools and lift night curfews? And while you answer that, let me add another question. Is it also the right time for large political rallies?
In my opinion, certainly schools. And this is something that we've been saying for a while. But I just want to point out that there hasn't been enough sensible discussion around this point. There has been clear enough integration of the information that is available around this point. And that's important because this is a decision that parents will have to take. Children, of course, are the most important and valued parts of our society. So there should be a building up of an idea of why it's important to open schools, a discussion of the costs of having schools closed for 2 years, what this means, and a discussion around the fact that if you open schools where children who have not been vaccinated go to, there will be a rise in cases, but this is very, very largely expected to be relatively irrelevant in terms of serious disease in children. We have to be aware of all of this. We have to take the decision as a society.
Absolutely.
What the implications of this might be.
I'll just add that
very important discussion.
I'll just add that these are issues that we have actually discussed with educationists and with others several times. I don't know why the Indian government insists on closing schools first and keeping them closed, because the truth is, even if children do get Omicron or the virus, they will not fall seriously ill. But before I come to Professor Kang, is this also the time to lift night curfews? They continue in Delhi. And what about political rallies? Remember, we have elections happening. What about these two?
I've always thought that night curfews were a silly idea. So I continue to think so. Political rallies, whenever you have large numbers of people making large amounts of noise without masks, that's not a good idea under any circumstance, whether it's a political rally or anything else, maybe even a concert. So that is in general a bad idea. Is it a bad idea now? Maybe a little less of a bad idea because many people have already caught some version of Omicron. And we can figure out what those numbers are, what the relative levels of seropositivity are. And certainly political activity is a part of a democracy. I would urge caution. I would urge mask wearing. I would urge smaller numbers. But maybe I would not rule out political activity altogether. That would be my bottom line.
Two very quick questions before I end, Professor Kang. First of all, am I correct in saying, and this is clearly the belief abroad, that even if children in schools do get Omicron or the virus, it will be a very mild case. There's no need to worry and certainly no need to close schools out of fear.
I think for me, the big thing that we have not done with regard to protecting children is identifying children with comorbidities and ensuring that we have the best possible vaccines available for them. For healthy children, you are absolutely correct. We do not anticipate a high rate of severe illness. The risk is very, very low. It's not like it's zero, but it's very low. And there are many other infectious diseases for which we do not vaccinate that have higher risks than SARS-CoV-2 does in children.
Absolutely, and we don't shut schools on that count. Therefore, it is silly to shut schools on this count and ensure that a whole generation of children is uneducated. My last question, Professor Kang, how important is mask wearing when Omicron remains the dominant variant? Britain has lifted the mandate. No longer is it compulsory. It's been left to the individual choice of every person. Should India move in that direction? Or do you think mask wearing remains the single best defense against infection?
I think when we think about masks, we need to think about two things. The first is how much virus is circulating outside. And if there is a high rate of circulation in general, whether that's SARS-CoV-2 or influenza or any other respiratory virus, wearing a mask is going to decrease the levels of infection, either protect the person who is wearing the mask or prevent that person from transmitting an infection if they have it asymptomatic. The second thing to consider is when you're around people who are potentially vulnerable. For example, if you have people who are immunocompromised, who've been transplanted, in whom you're unsure of how well they are likely to do when they get infected, I would suggest wearing masks around them and the best masks that you can afford to have.
But let me ask that question again. In the present circumstances, should mask wearing be compulsory, which is what it is outside your home in India at the moment? Or can that mandate be dropped?
I think outdoor masks, when you're not in a crowded situation, don't make sense. Indoor masks with people you're unfamiliar with, when there is a lot of virus circulation, makes sense.
That sounds delightful. So if visitors you don't want drop home, put on a mask very quickly. Whereas if it's with friends, there's no need to wear a mask. But it is a rather confusing situation, isn't it? Outdoor masks don't make a lot of sense. Indoor masks do. But it's outdoor masks that are required, and indoor, most people don't wear masks.
Well, I think that's why education is really important. And we clearly have not been doing a good job of teaching people when they should use masks and what kinds of masks.
But your suggestion is that outdoor masks don't make sense. Indoor masks do, particularly when you're in the company of people who are immunocompromised, because it will protect them. But also, if you are in the company of people who you are yourself not sure of, it will protect you. Those are two situations where indoor mask wearing would be wise.
Absolutely.
Thank you very much indeed. I thank both of you for joining me. Take care. Stay safe.